And good evening, everybody. And I've been asked to speak on various 2D echocardiographic views. Now, when you have the M-mode echo, that is actually a single plane ice-pick view of the heart. So that gives this limited information about the heart. So the heart being a three-dimensional organ, you need to have a various cross-sectional cuts as well as the sagittal and coronal cuts. And as you can see here, you have the long axis cut, which is the sagittal cut, which is plaques, and you have a series of short axis cuts in this view. So when you have the long axis cut, you are going to cut between from the base to the apex anteroposteriorly, and we call it the parasternal long axis view. It is obtained by placing the transducer in the fourth intercostal space at the left sternal border with the index mark at the 10 o'clock position. And when you do that, you'll get this sort of image. This, of course, is an artistic image. And when you see that you have an epicardial pad of fat anteriorly, the right ventricular free wall, the right ventricular cavity, the interventricular septum, the left ventricle, the chordae tendineae, and the papillary muscles and the posterior wall of the left ventricle. And at the base of the heart, you've got the aorta and the left atrium with the aortic valve and the mitral valve. So you can see, for example, like a wedge. Now, if you see over here that this is a wedge that is going through the heart, and whichever places the wedge connects. So in the parasternal long axis view, this index mark is pointing toward the right shoulder, and you are going to see that these semicircles is the ventricular septum. The rings are the tricuspid ring, the mitral ring, the aortic ring, and the pulmonic ring. So these are the valves, and the screws like here, these are the papillary muscles. So whichever structure it cuts, you're going to see that. So this is the parasternal long axis view. I hope everyone can see well. This is the parasternal long axis view. And you can see the heart in the parasternal long axis view, where the anterior wall of the aorta is continuous with the interventricular septum. The posterior wall of the aorta is continuous with the anterior mitral leaflet. The posterior wall of the left atrium is continuous with the posterior mitral leaflet and the posterior wall of the left ventricle. And behind the left atrium, you've got the descending aorta. So this is a good parasternal long axis view. And for an ideal parasternal long axis view, this aorta should be around about the 1 o'clock, 2 o'clock position. The left ventricular apex should be pointed out between the 10 o'clock and 11 o'clock position. And the left atrium should be between the 3 o'clock and 4 o'clock position, so that the interventricular septum and the posterior wall, as well as the anterior and posterior mitral leaflets, are cut by the ultrasound beam at right angles. And whenever the ultrasound beam cuts at right angles, you get the maximum delineation of the structure. So this is the view where you get the maximum delineation and for the best measurements. And you should have a good visualization of the endocardium of the IVS and the posterior wall, a good visualization of the aortic valve and the mitral valve. So you can see the moving clip now. And now you can have some variations of this view. And I'll go on to the next slide. Now this is the high parasternal long axis view. You move half to 1 intercostal space higher, and then you see that the interventricular septum, this LV cavity is pointed somewhat down, the aorta is pointed somewhat up, and you see more of the ascending aorta and less of the left ventricle. And it's a good view to actually visualize the size of the aorta beyond the sinotubular junction that you actually see from the classical view. The advantage of this view over the classical view is that you see more of the ascending aorta, and many times the ascending aorta dilatations and aneurysms are actually beyond the sinotubular junctions. So if you do not use this particular angulation, then in that case you can miss it. So again, the index mark is still at 10 o'clock position. Your probe is still at about the fourth intercostal space, say about half an intercostal space higher, and you are still, at the left parasternal position. So this is the high parasternal long axis view. Now we go on to this is another example of a high parasternal long axis view. And you can see the aortic valve, you can see the AR over here, and you can see that the aorta is pointed now somewhat upwards between the 1 o'clock position or so. This left ventricular apex is actually somewhat at about the 7 o'clock position. And this is the high parasternal long axis. Similarly then, you can have a low parasternal long axis position. In this case, you go half to one intercostal space lower than the fourth intercostal space. And now the apex of this will be pointed, apex of the left ventricle will be pointed at about the 1 o'clock position. The aorta will be around about the 3 o'clock to 4 o'clock position. The LA will be around about 5 o'clock position. And you'll see more of the left ventricle and less of the aorta. The advantage of this view is that you see more of the apical segments of the left ventricle. You see more of the apical segments of the left ventricle than you would see from the classical parasternal long axis view. And now you can go on from this view to the next view, which is the apical tilt. So from this, if you give an apical tilt, you will be actually looking at the LV apex, more toward the LV apex. And you can see that in this view, you can see a hypokinetic LV apex, which you are not appreciating from the low parasternal long axis view. So these are all the variations which should come as a reflex, that whenever you're doing a classical parasternal long axis view, taking the measurements, you also reflexly go through these various variations of this view. Next, we go on to the RV inflow view from the parasternal position. Again, the index mark is at the 10 o'clock position, but you're angling the probe inwards. You're angling the probe inwards, and you're going to image the right ventricle and the right atrium and the tricuspid valve. You can see the wedge. The wedge in this case is pointing now toward the right atrium and the right ventricle and the tricuspid ring. And what you're going to see is the eustachian valve. You're going to see the entry of the IVC and the coronary sinus, the right atrium, right ventricle, and the tricuspid valve. And this is an example now here. You can see the right atrium, you can see the right ventricle, the tricuspid valve, and you can see the entry of the IVC. Now, what you're going to see at this point is the septal leaflet of the tricuspid valve. If you angulate somewhat more, this leaflet will become the posterior leaflet rather than the septal leaflet. And the leaflet on the opposite side will always going to be the anterior leaflet of the tricuspid valve. And you see that you hardly see the left ventricle from this view. You only see the right atrium and right ventricle. So it's like a two-chamber view of the right ventricle from the parasternal position. A very good view to use. Next, we have the opposite angulation, that you make it an upwards and outwards angulation to visualize the RV outflow tract in the long axis. So you can see now the wedge is pointed toward the RV outflow tract, the pulmonic valve, and the main pulmonary artery. And you also see a portion of the mitral ring. So we call it the mitral pulmonic plane. Again, the index mark is at 10 o'clock position at the left sternal border, and you are angling the beam upwards and laterally, upwards and outwards. And that's how you will get this particular view. Still, the index mark is at 10 o'clock position, that is in the long axis position. Now you can see some example of this over here. You can see that this is the right ventricle outflow tract, this is the pulmonic valve, and you are part of the mitral valve, and somewhat better visualized when you slightly rotate from the 10 o'clock to the 11 o'clock position, and you can visualize here this pulmonic valve, the mitral valve, LV cavity. So this is the mitral pulmonic plane. So you can see the mitral pulmonic plane. It's a very useful view to actually see the mitral valve and the pulmonic valve in the long axis. Now you go to the short axis angulations. Now to go to the short axis, that is, you're going to the cross-sectional planes. So what are you going to do? You're going to rotate now this orientation of the beam clockwise from the 10 o'clock position to the 1 o'clock position. And as you do that, you see the aorta in the center. The patient's right side structures are going to come to your left side, and the left side structures of the patient are going to come to your right side. So you know that the pulmonic valve is a left side structure which is going to come to your right side. The tricuspid valve is a right side structure which is going to come to your left side. So you're going to have an RV outflow tract. Am I visible here? Yeah. This RV outflow tract is going to be anteriorly, and you're going to have the left atrium, you'll have the interatrial septum. So this is the parasternal short axis at the aortic position. And similarly, now you can see on the wedge how this is going to be. That these are the structures going to be cut. And this is the high short axis view. From this angulation, you can make it again a little bit higher, and you see the bifurcation of the pulmonary arteries. You can miss the pulmonic valve and the aortic valve. You just see the aorta, you see the right pulmonary artery, left pulmonary artery. You might be able to see the right atrial appendage. And you can see over here the echocardiographic picture showing the right pulmonary artery, left pulmonary artery, pulmonary, and the aorta, but not the valves. But you can get an intermediate position where you can actually see the valve as well as the pulmonary artery bifurcation. A very important view to actually look at the PDA, for example, or to look for the right pulmonary artery stenosis, the left pulmonary artery stenosis. And now you can see the moving clips at the aortic level. This is the classical aortic short axis view. You have the aorta, you have the right ventricular outflow tract, you have the pulmonic valve. You can see the cusp of the aortic valve, the right aortic cusp, this non-coronary cusp, and the left aortic cusp. You have the left atrium, and you have the left atrial appendage somewhere here, interatrial septum. So this view is a classical view for the aortic short axis. We can also call it the circle sausage view, where the aorta is a circle and the RV outflow tract anteriorly is a sausage. A very important view which you should never miss in any patient, because the orientation of the right ventricular outflow tract versus the aorta, the pulmonary artery, the relationships of the great vessels are best seen from this view. So therefore, this view should never be omitted. Otherwise, you can miss a lot of diagnoses, including the pulmonic stenosis, the PDA, for example. Now, this is the high short axis view. You can see the moving clip of the right short axis view, the right pulmonary artery, the left pulmonary artery, aorta, and you can see, so very important view to look at the PDA and to look at the right pulmonary artery stenosis, left pulmonary artery stenosis, the bifurcation of the pulmonary arteries, to look at the continuity of the main pulmonary artery with the right and left pulmonary artery. So that's a very important point sometimes in congenital heart disease, whether the pulmonary arteries are confluent or non-confluent. Next, we come to some variations of the short axis view. And one of this aortic short axis is to visualize the left atrial appendage. So slight angulation is required to get the left atrial appendage. See this left atrial appendage, a normal small left atrial appendage is being seen in this particular view. A normal small left atrial appendage in this particular view. And similarly now in the next view, you can have a variation for the right coronary artery. You can see the right coronary artery coming out at the 11 o'clock position. Can you see the right coronary artery at the 11 o'clock position at the aortic short axis view? So slight angulations are required to get these variations. So this is the right coronary artery. Similarly, you can get the left main coronary artery at about the 4 o'clock position. Sorry. So this is the left coronary artery coming out at about the 4 o'clock position. Yeah. Now you can take it at the level of the mitral valve, so that when you take it at the mitral valve, you're with this index mark at the 1 o'clock position only, that's the short axis position, you're going to angle the probe inferiorly and also slide it down slightly, so that you're going to cut the mitral valve, and that is the entry of the left ventricle. So you're going to look at the basal segments of the left ventricle, as well as you're going to look at the mitral orifice. You're going to look at the mitral orifice and the basal segments of the left ventricle. And this is the artistic view of the same. Generally, you'll not be able to see the tricuspid orifice on 2D echo. You can see it on 3D echo, but not on 2D echo. You only see the mitral orifice, the interventricular septum, right ventricle and the left ventricle. And these left ventricular segments are going to be the basal segments. So this is now at the papillary muscle position. At the papillary muscle is at the level of the mid-ventricle. So the mid-ventricular segments are going to be seen. You can see that the wedge is going to cut the papillary muscle level. And you're going to get the mid-LV. So I go, and then you can cut at the apex. That the apex is a nondescript structure between the papillary muscles and the tip of the left ventricle. So this you can see the short axis position at the level of the mitral valve. You can see the anterior leaflet, you can see the posterior leaflet, you can see the medial commissure, the lateral commissure, and it's a good view to take the mitral orifice area in the short axis position, and also good view to look at the contractility of the basal segments of the left ventricle. Now this is at the level of the papillary muscles. You can see the moving clip here. That is the, and this is at the level of the apex. Now we go to the, from the short axis position, we go to the apical positions, and we go to the coronal view. And you know the coronal view is cut from the base to the apex in a coronal direction, and you get what is called the apical four-chamber. How do you get this view? So what you do is you place the transducer at the apex, and you move the index mark from the 1 o'clock position to the 4 o'clock position. And you visualize the four ventricles and these four chambers of the heart. That is the right and the left ventricle, the right and the left atrium. And you also visualize the mitral valve and the tricuspid valve. And you can see that as you put the transducer, you are actually able to see the four chambers, and you can see the wedge, which is going to cut the mitral ring, the tricuspid ring, the interventricular septum, the left ventricle, the right atrium, and the left atrium. So this is how you get this view. And this view you can see over here very clearly. You should have certain features are to be noted about this particular view. That this should be an absolutely straight view. This view should be absolutely straight. The left atrium, this left ventricle should form right in the middle of the sector. This left ventricle should be at the tip of the sector, and you should be able to see the four chambers. You should see a long extent of the left ventricle. The long extent of the left ventricle means that this left ventricular length should be at least 8.5 centimeters. If you measure it from the mitral annulus to the tip of the LV, it should be at least 8 to 8.5 centimeters. If it is less than 8 centimeters, you are likely to get a foreshortened view. So because in a good window, you can get a series of four chamber views, but many of them are going to be foreshortened. The one that you are going to take is the one which is going to have the longest LV. The longest LV is the one that you have to take. And when you take this view, you get the ventricular septum. When you're looking at the LV, you are looking at this ventricular septum medially. You are looking at the LV lateral wall, the laterally, and you can see the functioning of these chambers. You can see the functioning of this chamber. You know, the interventricular septum that you're going to see is not the same interventricular septum that you get from the parasternal long axis view. Here, what you're going to see, the interventricular septum is going to be the more posterior septum. We call it the basal infraseptal, the mid infraseptal. These are the territories of the right coronary artery. While from the parasternal long axis view, where you get the aorta in position, that is the territory of the LAD. Now, the apical part of the IVS is actually the territory of the LAD. The lateral, this lateral wall of the LV is actually the territory of the circumflex coronary artery. That is the obtuse marginal branches of the circumflex coronary artery. And as you know, the apical segment of the lateral wall is also supplied by the LAD. So now from the four chamber view, we go on and we go to the two chamber view. Now this is the diagrammatic representation of two chamber view using the wedge. Now here for that, we are going to rotate the transducer from the apical four chamber view to the apical two chamber position. And so therefore it's going to point at the 1 o'clock position. That is the short axis position, but obtained from the apical position. So you'll get the short axis view, but actually it's a two chamber view because you are at the apex. So you are at the 1 o'clock position as far as this position of the index mark is concerned. So in that case, you're going to get the two chamber, the left atrium and the left ventricle. And you can see the two chambers which are moving over here. These are the two chambers. And you have the left atrium, the left ventricle, and you have the mitral valve and the atrial appendage. Now this view, you should obtain it very slowly as you rotate counterclockwise from the four chamber view to the two chamber view. And as you rotate counterclockwise, you're going to get the inferior wall on the left and the anterior wall on the right. The inferior wall is the territory of the right coronary artery. The anterior wall is the diagonal territory, that is the diagonal branches of the left anterior descending artery. And you can also see the atrial appendage, just at the atrial appendage. So this is a good view to actually look at the atrial appendage. This is a good view to look at the atrial appendage. Now we go on to the apical five chamber view. Now the apical five chamber view is again that you go back to the four chamber view with the index mark at 4 o'clock position. Now you have to move the beam, ultrasound beam, anteriorly and make it superficial. So you have to move the probe anteriorly towards you so that your beam is now going to cut the aortic valve also. And you can see the wedge is cutting the aortic valve, and you're opening up the fifth chamber, that is the aorta. So again, it's a very important view because you can look at over here this stroke volume of the left ventricle by taking the VTI at the left ventricular outflow tract. You can also take the gradients of the aortic valve. And again, you should remember that the interventricular septum you are now going to see is the anterior septum, which is going to be supplied by the LAD and not by the RCA, as was seen in the four-chamber view. And the opposite wall is going to be the inferolateral wall or the posterior wall of the left ventricle, supplied generally by the posterior LV branches of the circumflex coronary artery. So this is a classical apical five-chamber view, a classical apical five-chamber view that you can see over here. Next, we come to the apical long axis view. That is the long axis view of the LV but the transducer from the apex. So you know that the long axis position is the 10 o'clock position. The long axis position is 10 o'clock position. And from the 10 o'clock position, you are going to see this particular position. So you are going to rotate the probe further counterclockwise from the two-chamber view to the apical long axis view. This is also called the apical three-chamber view. This third chamber being the aorta, the left atrium, the left ventricle, and the third chamber is the aorta. It's a very good view to actually see the wall motion of the left ventricle from the apical position, and is now the preferred view to use in stress echo packages. So you can see how the wedge is there. The wedge is going to cut the interventricular septum, the mitral valve, the aortic valve, and the left ventricle and the left atrium. And you get the three-chamber view or the apical long axis view. And this is the moving clip. You can see very clearly the moving clip from the left atrium to the left ventricle. Now from this position of the apical four-chamber view back and move slightly toward the two-chamber view, you're going to get what is the apical short axis view. Now, how do you get the apical short axis view from the apex? So what you do is that from the apical four-chamber view, slightly rotate this probe toward the two-chamber, but not quite. So instead, from the 4 o'clock, you make it to the 2 o'clock position. And then you move the probe slightly higher and bend the probe down toward the apex. And as you do that, you get a nice cross-sectional view of the LV apex. The nice cross-sectional view of the LV apex is seen over here. Yeah. So you can see that this apical is a very useful view to look at the apical wall motion as well as to look for any LV apical plots. Now, sometimes you get on the 2D echo, especially if the apex is dilated like an apical aneurysm, you get near field artifacts. We call it a near field clutter, which looks like a plot. And since you're looking for a plot, you sometimes wrongly diagnose as a plot. But once you do this view, this near field clutter will disappear. And if there is a plot, that will get highlighted. So a very good view to differentiate artifact from a clot. The other advantage is that, of course, you can look for apical tumors. You can look for the obliteration of the LV apex that can occur in LV apical hypertrophy or in the non-compaction of the left ventricle. Now, this is another apical angulation, which is not very frequently done by people, but I find it to be very useful. And this is what is called, I call it the biventricular view. Now, the biventricular view is got by moving the transducer from the apical four-chamber slightly higher and rotating the probe slightly toward the two-chamber, and then bending the probe slightly only so that the beam, ultrasound beam, exits at the atrioventricular junction, and you get the coronary sinus delineated at the base of the heart. You miss the LA and the RA. So you only get what is called the biventricular view, the left ventricle and the right ventricle. It's a very useful view because what you're seeing over here is the diaphragmatic wall of the right ventricle from the apical view. See, normally you get the diaphragmatic wall of the right ventricle from the subcostal view. But here from the apical view, you can get the diaphragmatic wall of the right ventricle. And sometimes in inferior wall infarction, in about 1/3 of cases, the right ventricular involvement is actually shown only by the involvement of the diaphragmatic wall. And that is one advantage. The other thing is that the basal infroseptal, you get the most basal infroseptal region, which can sometimes get ruptured during an inferior wall infarction. So the post-inferior wall MI VSD is best seen in this view, which is normally not seen from the classical apical four-chamber view. So it can be sometimes a very embarrassing situation that you miss the VSD in the this apical four-chamber view, post-inferior wall MI, because you are not just performed this angulation. Again, I always recommend that this should be a reflex. It's not a difficult view, you just have to practice it a few times. And then once you make it a reflex, and when it actually required, you are able to obtain this view. So you should have this view in your armamentarium, though it's not mentioned in most of the textbooks also, but I would strongly recommend that this angulation should always be practiced. Now from this biventricular view, we go on to the what is now called, it was previously we used to call it the apical two-chamber view of the right ventricle. We are now calling it the focused four-chamber view of the right ventricle. So in this focused four-chamber view, you're slightly from the apex, from the apical four-chamber position, index mark at 4 o'clock, you're just going to move the probe slightly laterally and then angulate medially, extreme medially, so that you can see more prominently the right atrium and the right ventricle. The apex is going to be formed more by the right ventricle than by the left ventricle or by both the ventricles. But you'll get a view of the right atrium and the right ventricle very prominently. And it's a very good view, not only for the overall RV function, but to visualize the TR jet, which you usually do. Just let me go back and I'll show you the moving clip. Here, yeah. So this is the moving clip. So you can see the right atrium, right ventricle from the focused apical four-chamber view, which previously we used to call the two-chamber view of the right ventricle. And we can see the coronary sinus draining into the right atrium. You can see the coronary sinus draining in the right ventricle. And you can also see the anatomy of the right ventricle, that is the moderator band. The moderator band defines that this is actually the morphological RV, whether it's on the right side or the left side. As you know, in many complex congenital heart disease, this right ventricle may actually be on the left side. So this is a very important, this moderator band is a transverse band of muscle between the apical 1/3 and the basal 2/3 of the right ventricle. And you can see this very clearly from this particular view. Now we have finished the apical positions, and now we go on to another coronal view, which is the subcostal view. Now the subcostal view is a coronal view, but actually it is cut from side to side rather than from apex to base. So it's cut through the diaphragm from the right ventricle wall to the left ventricle to the IVS and then to the left ventricle. And now it is obtained, the four-chamber view from the subcostal position is obtained by placing the transducer in the epigastrium. Ask the patient to take a deep breath. The transducer should be pointed slightly toward the left ventricle, slightly to the left, and the index mark is at 4 o'clock position. In that case, you'll get a four-chamber view of the right ventricle, a very useful view to have, and you should always perform in every patient. It's very easily obtained in children, but sometimes in obese patients, you are not able to get a good quality apical four-chamber view. But this view is very useful sometimes in patients with chronic obstructive airway disease, where due to hyperinflated lungs, you do not get a good transthoracic image of the heart, either from the parasternal or the apical, either of them, or from both these positions, you are not able to get a good view of the heart. But before you give up, always go to the subcostal view, which will be very good in these patients. In the patient with COPD, the subcostal view is going to be very good and will bail you out at this point. And you can get the various angulations, that is the four-chamber, the short axis, the two-chamber, the long axis angulations, all from the subcostal position. Now, this view is, as I said, very good in children. So the pediatric cardiologist exclusively use the subcostal position to obtain all the angulations. So it's a very useful view. The advantage is that the interatrial septum that you see over here, the interatrial septum is at right angles to the ultrasound beam. Therefore, you get a very good delineation. And if there was an ASD, the flow will be from left atrium to right atrium, will be parallel to the ultrasound. So you get both the conditions for the imaging are satisfied, that you should be at right angles to the structure and you should be parallel to flow. So once you see this, you are very sure that, you know, the interatrial septum is intact. Sometimes there can be an echo dropout from the four-chamber view, because normally the fossa ovalis portion of the atrial septum is normally thinned out. And from the apical four-chamber view, the straight view, as I said, the correct view, apical four-chamber, the atrial septum is actually parallel to the ultrasound beam. So therefore, there is generally going to be an echo dropout. And if the right atrium and right ventricle are dilated due to some other cause other than atrial septal defect, your first thing that comes in your mind is ASD, and you get an echo-free space in the mid-atrial septum, which is an echo dropout, and you wrongly call it an atrial septal defect. And when you put the color on, the adjacent flows along the atrial septum can sometimes appear to cross from the left atrium to right atrium, and you can make a wrong diagnosis of atrial septal defect. From this position, the atrial septum is actually at right angles to the ultrasound beam, and you're parallel to flow. That is one advantage. The other is to take the thickness of the right ventricle for the diagnosis of right ventricular hypertrophy. The right ventricular hypertrophy you're going to diagnose from this view. From the subcostal position, you can take the thickness in diastole. So that's a very useful thing to have, is this particular view. You can also look at the right ventricular function in general. So very important view, this particular subcostal, and you can get various other angulations as we go along, and not just the four-chamber view. Now, as you go on to this actually is the four-chamber view. You're showing the wedge, how the wedge is going to cross the diaphragmatic surface of the right ventricle, and then across it into the right ventricular cavity through the tricuspid ring, across the ventricular septum into the left ventricle. This is how the image is going to be formed. And this is the four-chamber view. This is the subcostal four-chamber view. Very, very useful view to have. Now you can take a variation of this. You can take what is called the subcostal short axis. So as the name implies, you're going to move the index mark from the 4 o'clock position to the 1 o'clock position. And you're going to make the probe a little superficial. So you can also see the aorta. So it's also called the subcostal short axis RV inflow apical outflow view. It's a very good view, and you should do it in every patient, because you can visualize the right ventricular outflow tract, the main pulmonary artery and right pulmonary artery, the right pulmonary artery, which you may not be able to see sometimes from the transthoracic position because of either deformity of the chest or because of the inflated lungs. You may not be able to see the RV outflow tract, and no echocardiographic examination is complete unless you see the RV outflow tract, the main pulmonary artery, and the PA bifurcation. And in this view, if you're not getting a good view of the RVOT from the transthoracic, then the subcostal view is very good, which bails you out in many cases, as I said. So this is the subcostal short axis position. And here you can see now this index mark has been put into the 1 o'clock position, and this is the orientation of the wedge. It's going to cut, and you get this particular image from the subcostal position. It looks like a short axis view, as you can see here, but the only thing is you can see the hepatic tissue. So once you see the hepatic tissue, you know that this is a subcostal short axis position. You can either get the atrial septum or you can get the SVC by just changing the angulation slightly, and you can see the SVC into the RA. And by rotating the probe slightly to the right, you can actually get the IVC. So you can get some sort of this equivalent of a bicaval view here. So from the subcostal view, you can get an equivalent of a bicaval view, which actually you do not get from most of the transthoracic position unless from the right parasternal view, as we'll see afterwards. That from the right parasternal view also you might sometimes get, but the subcostal view is more easy to get in many patients. and you can get sometimes a bicable view. Now, this is the subcostal short axis view. Now, this is the subcostal short axis view at the level of the LV. So you can bend the probe. Now I'm going back, and I'm going to play this again from the subcostal view. So this is the subcostal view, short axis view at the aortic level. You can see the aorta, you can see the right ventricular outflow tract, you can see the pulmonic valve, you can see the main pulmonary artery, the right and the left pulmonary arteries, you can see the intra-atrial septum, right atrium, left atrium, and you can see the right ventricle. So much of information in this particular view, but of course, these are somewhat compressed. So these are and foreshortened, but otherwise give you a good relationship. And you can also see the bifurcation of the right pulmonary artery and the left pulmonary artery from the subcostal position. So this is the subcostal short axis at the aortic position. And similarly, you can now bend the probe down to look at the subcostal short axis of the LV at the papillomuscle and the apical position. Now, this is the subcostal short axis at the level of the LV apex. The subcostal short axis at the level of the LV apex. So this is a patient who has got cirrhosis of liver. So you can see a shrunken liver, and you can see a lot of ascites, but you can also see the subcostal short axis view of the left ventricle at the apical level. Now you can visualize the long axis view. So you just rotate the transducer from the 1 o'clock position. You will rotate the transducer from the 1 o'clock position to the 10 o'clock position, counterclockwise, and you'll get the long axis. So if you're not able to get a good parasternal long axis view from the transthoracic position because of the hyperinflated lungs or chest deformity, so you can use the subcostal long axis view. You see the subcostal long axis, you can get the left atrium, left ventricle, mitral valve, aorta, right ventricle. Though somewhat foreshortened, but it gives you a good idea about the valves, aortic valve and the mitral valve, as well as the relationships of the structures. You can see it very well. So this is called the subcostal long axis view. So very important view sometimes. So you should always have it in your armamentarium in case you are not able to get a good subcostal, you are not able to get a good parasternal long axis position from the transthoracic, then this can be used from the subcostal position. Now we move on to the next view of the subcostal, that is the abdominal aorta. So here all that you need to do is to angle posteriorly. And as you angle posteriorly, you get the long axis of the abdominal aorta. You can rotate the probe and you can get the short axis right from the epigastrium to the umbilicus. Now, as you do that, you're actually going to see the aorta, and you can diagnose abdominal aortic aneurysms, which many times occurs as an incidental finding. The patient is not complaining, they are undiagnosed. So to detect undiagnosed abdominal aortic aneurysm, this is an excellent view, because you should be doing it. As you're doing echo, you hardly have to spend another 10 seconds and you will be able to see the abdominal aorta in its entirety. And if you want, you can also see the branches. You know that the first branch is the celiac axis, the second branch is the superior mesenteric artery. And of course, if you are interested in the Dopplers of the renal arteries, you can also get that. But what I'm talking is that as a routine, the abdominal aorta should always be imaged. Even if you are not asked to do it, you should always image the abdominal aorta when you're doing a routine echocardiographic view from the subcostal position. Now you can rotate the beam slightly to the right. What you can do is that you're going to move the transducer slightly to the right, and your index mark is going to be at about the 1 o'clock position. And you can see the abdominal aorta and even the IVC. You can see the IVC entry into the right atrium, and you know the IVC is very important, the landmark. IVC is also important for the hemodynamically to look at the central venous pressure. And in this particular case of cirrhosis of liver, you can see that the IVC is very shrunken because of the relative hypovolemia that you have in such patients. You have got a shrunken IVC because of a relative hypovolemia because of the hypoalbuminemia. This fluid is going to exudate into the third space. So this is what you're going to get is the IVC view. and you can see both the abdominal aorta and the IVC, and you can angulate further to the right to actually see only the IVC. Now, after that, we are going to have the suprasternal views. For the suprasternal views, you are going to have the patient placed in the supine position. The shoulders should be hyperextended neck, so the shoulders should be slightly elevated. Sometimes you need to put a pillow beneath the shoulders to actually hyperextend the neck. The index mark of the probe should be at the 1 o'clock position, and you should put the probe in the suprasternal notch. Now, in the newborns and infants, the suprasternal notch is actually very small. So what you can do is just to place the transducer over the manubrium sterni, because you know the manubrium is not ossified in the newborns or in the infants. So you get a good, very good view actually of the suprasternal region, even in newborns and the infants. And of course, in many adults, you are able to get a good view of the suprasternal. Now, when you're putting the marker at the 1 o'clock position, you get what is called the suprasternal long axis view. So in this schematic diagram, what you're going to see is the ascending aorta, the transverse aortic arch, and the descending thoracic aorta, as well as the origin of the innominate artery, the left common carotid and the left subclavian arteries. You visualize the isthmus region of the aorta, that is the junction of the aortic arch with the descending thoracic aorta. So you can visualize ascending aortic aneurysms, aortic dissections, the aneurysms of the aortic arch and the isthmus region. You can also look for coarctation of aorta. You can look at the backflow in the descending thoracic aorta that you see in aortic regurgitations. And as I said, you can look at the gradients across the descending thoracic aorta, across the coarctation of aorta. So you can also look at the patent ductus arteriosus. Sometimes this is best visualized from the suprasternal position between the aortic isthmus or just beyond the aortic isthmus and the main pulmonary artery. So you can see the aortic arch, and then from the aortic arch, just beneath the aortic arch, you see the right pulmonary artery, which actually appears in short axis. In the long axis of the ascending of this aortic arch, you're actually seeing the short axis of the main pulmonary artery. And behind the main pulmonary artery is the left atrium. And you can see sometimes the entry of the pulmonary veins. And you also can sometimes see the aortic valve. Most of the time, you don't see the aortic valve from this point, except in children. But you see some portion of the ascending aorta. You definitely see the aortic arch, and you see the descending aortic valve. It's also a good view to look for aortoarteritis. So you can see the origin of the left subclavian artery, the left common carotid artery, the innominate arteries, and sometimes you can take the gradients across these to actually you can quantitate the degree of stenosis at these levels. Now this is how the wedge is there. You are going to image the aorta in the long axis. You can arch the right pulmonary artery, and this is again to show you the moving clip. Now this is the moving clip of the suprasternal long axis view. This is the suprasternal long axis view. And as you move this clip, so you can see that here, the most superior wall of the left atrium. The superior wall of the left atrium is not seen from any other view except this view, and you can get some idea about the left atrial function. But more importantly, you're seeing the right pulmonary artery, you're seeing the arch of the aorta, the arch branches, and you're seeing the descending thoracic aorta. And this is the view that is used, very important view for aortic dissection. So this is the suprasternal long axis view. Now then, what you're going to do, of course, you can see over in this image the ascending aortic aneurysm. Ascending aortic aneurysm is diagnosed from the suprasternal view. Now you go on to the suprasternal short axis. Now in the suprasternal short axis, you're going to get the long axis of the right and the left pulmonary arteries. So from the 1 o'clock position, if you rotate to the 10 o'clock position, if you angle to the right, you'll get the long axis of the right pulmonary artery going behind the SVC. And if you angle to the left, you'll get the long axis of the left pulmonary artery going over the descending thoracic aorta. So again, a very good view, a suprasternal short axis view to actually visualize the pulmonary arteries. Now, if you are not able to visualize the pulmonary arteries from the parasternal position or from the subcostal position, the suprasternal view is a very good position to actually see the individual pulmonary arteries. The individual pulmonary arteries is very well seen here. And you can see here that this is, for example, I'm so sorry, I'll just go on to this view. Yeah. So you see the right pulmonary artery, the long axis of the right pulmonary artery. You see on top of that the aortic arch. So you see a shorter axis of the arch of the aorta, but a longer axis of the right pulmonary artery. And on top of that, you see the left innominate vein. The left innominate vein, you know, is anterior to the arch of the aorta. And behind the right pulmonary artery, you know, is the left atrium. So it's a good view for the right pulmonary artery. And similarly, as you angulate to the left pulmonary artery, here, as you angulate to the left side from the short axis position, you are going to get the suprasternal short axis view for the left pulmonary artery. You're going to get the arch of the aorta and you'll get the innominate vein. So this is the left pulmonary artery angulation. And then you get what is called the supraclavicular view. This right supraclavicular view is actually got, so this right supraclavicular view is actually obtained, as you can see over here, by placing the transducer in the right supraclavicular position just next to the suprasternal notch. And you can get the long axis of the SVC just beyond where it is being formed, and to some extent the mid segment of the SVC. You do not get the terminal segment as it enters the right atrium. And you can get the SVC, you can do the pulse, this color guided pulse Doppler of the SVC, which sometimes is very useful in our experience. The SVC interrogation sometimes is very useful. Sometimes when you do it in dialysis patients, especially, and you look for SVC blocks, the SVC interrogation is very important. So this is the right supraclavicular view just next to the suprasternal notch, index mark at 1 o'clock position, to look at the SVC. After looking at the SVC, we go to the right parasternal position. Now the right parasternal position, you have two views. You have the right parasternal lower position, which is at the 4th to the 5th intercostal space. You turn the patient to the right side and you place the transducer index mark at about the 1 o'clock position, and you are going to image the right atrium anteriorly, the left atrium posteriorly, in between that the atrial septum, and you also image the SVC and the IVC. So another view that you can get to image the SVC and IVC. This view is more easily obtained in children and the young adults. Many times in the older patients it's not that easy to obtain this view. But it's a very good view again for the atrial septal defect, because again this ultrasound beam has right angles to the atrial septum, and if there is a ASD, you are parallel to flow from the left atrium to the right atrium. You are actually parallel to the flow. So it becomes a very useful view to actually use the atrial septal. So again, this is the diagrammatic view of the SVC, the IVC, the right atrium from the right lower parasternal view. Then you come to the right upper parasternal view, which is most useful and more easily obtained in most patients. That is, as you turn the patient to the right side, you put the transducer in the second intercostal space at the aortic area 1, at the second intercostal space, index mark at 1 o'clock position. And you can see if the patient has got aortic stenosis, you can see the jet of aortic stenosis. You can also visualize ascending aortic aneurysms, and you can visualize dissection of the ascending aorta. That is another very important implication of this view, that you can actually visualize the gradients across the aortic valve. Very importantly, because many times from the apical 5 chamber, you are not able to get parallel, you do not get a good delineation. In every patient with aortic stenosis, besides doing the apical 5 chamber view for the gradients, you should be doing this particular view to look at the gradients across the aortic valve. And I said, in any suspected dissection of the ascending aorta, this view is very important. For aortic aneurysms, this view is very important. And next to the ascending aorta, you get actually the main pulmonary artery. And on the right side of the ascending aorta, you get the SPC. Now, this is from the right parasternal view, we have diagnosed the ascending aorta aneurysm in this particular patient. And this is the patient with aortic stenosis. So you can see that in this particular patient, you can get parallel to the jet of the aortic stenosis. So this is the jet of aortic stenosis, and you can get the gradient across the aortic valve very clearly, as you can see in this particular patient. And just before we end, we've got a couple of views. One is the view from the back. Normally, if you put the transducer at the back, you hardly see anything. You can see if you are good at the lung ultrasound for the lung water, you can see the curly lines. But besides that, you hardly see anything because the lungs are inflated, and the air is a bad medium for the ultrasound transmission. But once you get a passage, you get an acoustic access, and that acoustic access is because of pleural effusion. So when you get a left or the right pleural effusion, you can visualize from the back. You make the patient in the sitting up position, and you put the transducer either in the right suprascapular, this right midscapular, or the left midscapular, or the left infrascapular regions to look for any pleural effusion. Now, if there's a pleural effusion, you can visualize the heart through that pleural effusion. You see first the left ventricle and then the right ventricle. You get the posterior wall of the left ventricular cavity, interventricular septum, the right ventricle, and you get the right pleural fluid, and you can get the image of the lung. Otherwise, the lung is not imaged. Here you get the image because this is a collapsed lung. There's atelectasis of the lung because of the pleural effusion, and you get a consolidated lung which is highly echogenic. So it's a very good view to actually diagnose pleural effusions. And as cardiologists, we should always be looking out for pleural effusions also, not just for pericardial effusions. We should be looking out for pleural effusions. And we should be looking out for this pleural effusion either on the right side or the left side. This patient has a left pleural effusion, and you can see the left ventricle. Sometimes there is a problem from the transthoracic view, whether that is a loculated pericardial effusion or whether actually this is a pleural effusion. It can be very problematic at times. And therefore, this view from the back will solve everything, will resolve all the problems. So this is very important. And you can also diagnose pleuropericardial effusion, both pleural effusion and pericardial effusion. As you can see, there is both pleural effusion and pericardial effusion in this patient. This is the left ventricle short axis from the back. This is the left ventricle short axis from the back. You're getting two layers of the echo-free space. The first layer is the pleural effusion, then you have the pericardial effusion. So you have a pleuropericardial effusion. Again, the view from the back is very important. You should never miss it in any patient that you're doing it, especially when you want to look for pleural effusions. In patients with elevated LV EDP, you want to look for, in the patients with heart failure, you have to look for pleural effusions also. Now, sometimes you can get an acoustic access from the back because of the descending thoracic aorta aneurysms. Normally, the descending thoracic aorta is blind to a transthoracic examination. But sometimes when there is a descending thoracic aorta aneurysm, you can actually image by placing the transducer in the left paravertebral region. And as you place that, you can get if there is an aneurysm, you can image the aneurysm. This is the patient with the dissecting aneurysm of the descending thoracic aorta, which you have imaged on the back. And you can see L1 and L2 indicating the two lumen. And you can see that the false lumen, that is L2, which is the larger lumen, is actually clotted. The TH stands for thrombus. A very, very useful view sometimes if there's a descending thoracic aorta. Normally, you would like to look at actually the transesophageal for looking at the descending thoracic aorta, but occasionally this can become very handy. So actually, I've gone over all the views that are available, and many of them are unconventional views, which you not normally find in many of the textbooks, but I think you should always have them in your armamentarium. They may not be in the guidelines of many of these recommendations, but most of the time you are going to actually you should be able to utilize these views, and if you only keep in touch with these views, that's very important. Thank you very much. So I'll be most willing to take any questions.
Thank you so much, sir. That was very simplified and very, very detailed presentation indeed. Thank you so much once again on behalf of all the participants. There are a lot of compliments that are coming your way, and I will keep passing on the questions to you. So the first question is from Dr. Ganpati, Mr. Ganpati or Dr. Ganpati. Out morphological RA, LA, RV, and LV through echo.
Yeah. So the morphology of the right atrium, the left atrium, that actually comes in a different topic, but I will explain to you. See, the morphology of the LA and the RA, if you take, is from the atrial appendage. Now, the left atrial appendage, you know, is a longish appendage. It's a finger-shaped appendage, which has a small base but a long length. As opposed to that, the right atrial appendage is a broad-based appendage but rather short. So the atrial appendages, they could differentiate the right atrium and the left atrium. If you get all the 4 pulmonary veins well seen, or at least 3 of the 4 pulmonary veins well seen, then that chamber has to be the left atrium. And also, if you get the right IVC and the coronary sinus opening into, then that chamber has to be the right atrium. As far as the right ventricle is concerned, the morphology of the right ventricle, I partially said that you make out from the shape of the right ventricle has more of a triangular shape, but more importantly than, you look at the moderator band. The moderator band is actually a transverse band of muscle, which is a modified papillary muscle, which goes from the right ventricular free wall to the interventricular septum. And that is present in almost every patient, and it identifies the right ventricle in whichever place it is, whether it's on the right side or the left side. The other way to look at the right ventricle is that of the tricuspid valve, the position of that versus the anterior mitral leaflet. So you have normally the septal leaflet of the tricuspid valve is slightly more apical in position by 1 to 2 millimeters normally. But if it becomes 1 centimeter to 1.2 centimeters, usually is 0.8 centimeter per meter squared, then we call it Epstein's anomaly. But otherwise, normally you get what is called offsetting. That is, the septal leaflet of the tricuspid valve is somewhat in an apical position. Generally, the chordae of the tricuspid valve are not connected to they are actually more likely to be connected to the interventricular septum than the posterior wall, while the left ventricle of the left ventricle, not to the ventricular septum. So if you have a caudal connection to the ventricular septum, is more likely to be the right ventricle than the left ventricle. That is another way to actually say that this is it. Of course, if you get a fish mouth appearance of the mitral valve, that will identify the left ventricle. Always remember that the atrioventricular valve, it identifies the chamber. If you have the mitral valve, then that chamber is the left ventricle. You cannot have a mitral valve on the right ventricle. Similarly, if you have if you have identified the valve as the tricuspid valve by the position of the septal leaflet of the tricuspid valve, then in that case, that has to be the right ventricle. So is that okay with me? This left ventricular cavity is always a clean cavity normally. Or if you see the left ventricular apex, especially from the fetal echo, we identify the left ventricular apex is clean. The right ventricular apex is actually obliterated by the trabeculations and by the moderator band. Thank you. Any other question?
Yes, sir, there are a lot of them. So the next is from Mr. Islam. I think he's asking you to comment on off-axis view. Can you mention something about off-axis view?
Yeah, very important. See, normally, if you want to look for the apical four-chamber view, normally you like to have a straight view, as I was saying, that one of the requirements, one of the prerequisites of an apical four-chamber view, that should be straight and not off-axis. If you want to observe the left ventricular wall motion, and you want to observe the left ventricular function, you want to estimate the volumes, you should always have a straight view. But sometimes the off-axis view, if you are getting this are not good views for the wall motion. You should never comment on the wall motion from the off-axis view, and you should always try to get straight views. But sometimes the off-axis view could be useful to visualize the atrial septum better. As I said, if you get a straight view of the apical four-chamber view, then you get an echo dropout in the mid-atrial septum normally. To overcome that, you go into the off-axis position, and then you'll get a well-delineated atrial septum. So what was looking like an atrial septal defect will now appear to be an intact atrial septum once you go to the off-axis position. Is that okay? Yes, you can go to the next question.
Yeah, the next question is, what are the views to visualize pulmonary veins?
Yeah, the pulmonary veins, actually, the main view that you're going to use is going to be the apical four-chamber view, or you can use the subcostal view. These are the two views that you're going to look at the pulmonary veins. Now, if you take the apical four-chamber view, the right superior pulmonary vein, that comes very close to the atrial septum, it comes a little horizontally. What you get as a vertical vein is actually a right inferior pulmonary vein. There's a lot of confusion in the literature whether that should be the inferior pulmonary vein or the superior. I prefer to call it the inferior pulmonary vein, which you get vertically connected just next to the atrial septum in the atrial. And you get the other two pulmonary veins are generally seen easily. The left superior pulmonary vein is seen next to the atrial appendage, while the left inferior pulmonary vein is seen at the roof of the left atrium on the left side. So these are the pulmonary veins, and the same veins sometimes you can see from the subcostal position.
Perfect. I think you just answered
about the pulmonary veins.
Yeah, you just answered the next question, which was how to view atrial appendages. So I'll move on to the next question. The
atrial appendage.
Yeah. So can I take the next question?
Yeah, please.
Yeah, so parasternal short axis view should be seen from which intercostal space?
So parasternal short axis view is always seen about the fourth intercostal space or so. Sometimes, these patients are built differently. So sometimes you might get it from the fifth, or sometimes you might get it from third, but generally most of the time you'll get from the fourth intercostal position. Left sternal border, index mark at the 1 o'clock position. So you'll get the parasternal short axis view, and you get at the aortic level, you'll get at the high pulmonary artery level, you'll get at the level of the mitral valve, the papillary muscle. These are the views that you're going to get, or you can get at the apex.
Sure, sir. And the second question is also around, how to visualize 4 pulmonary veins easily altogether.
See, you may or may not be able to see all the 4 pulmonary. You may require special angulation sometime to make to the right or to the left from the apical four-chamber view. But many times you're able to get at least 3 pulmonary veins seen easily. The right inferior pulmonary vein, which comes vertically, and very useful to, if you want to interrogate the pulmonary vein Doppler for the LV-EDP estimation. That's a very good view to actually interrogate the right pulmonary vein. You have to put the color Doppler on, and you have to lower the scale to about 20 centimeters per second, or even sometimes lower. And the left pulmonary vein is just next to the atrial appendage, which is going to move downward. You'll get a blue colored flow over there. And you'll get the left pulmonary vein, the inferior pulmonary vein very close by, which will be closer to the roof of the left atrium, which will again, you'll have a red color flow coming. So the apical four-chamber view or slight modifications of it is sometime that you're going to be used. So if you want to look at if you're going to look at the left pulmonary vein, then the apical two-chamber view will be very useful, because the apical two-chamber view, this LA appendage is well visualized in the apical two-chamber view, and the left superior pulmonary vein is just bordering the LA appendage.
So the next question is from Dr. Rajesh. How to differentiate between different aortic flow reversal?
Now, the aortic flow reversal is sometimes we use in aortic regurgitation or we use in PDA, but mainly in patients with aortic regurgitations. Now, I think you had a lecture from Dr. Kasliwal on that also.
Yes, sir.
I think he must have mentioned it. Now, what you do is you do the suprasternal view. Now, in the suprasternal view, you put the color on. And normally the descending thoracic aorta, the flow will be blue in color, which is going away from the transducer. Now, you'll get some red flow if there's a flow reversal. And that will generally come on along the medial wall of the aorta. And if you get that flow reversal, you put the pulse Doppler sample volume. If the flow that is toward the transducer, that is the reverse flow, that is red in color, and on the pulse Doppler, it is above the baseline, then in that case, it's either going to be, if that is going to be very short, which is quite normal, but if that is seen in very mild AR, in a moderate AR, it might be a little more reversal, occupying little more of the diastole, but not pan-diastolic. But if you get a pan-diastolic reversal, that generally indicates a severe AR. It indicates more than moderate AR or a severe AR. So this is the type that you get in aortic regurgitation. Sometimes this will also be seen in PDA. So if you're looking at a pediatric patient, you're looking at a flow reversal, then try to image the PDA properly and to actually say that this is due to PDA.
Okay, so yeah, so the next question is from Sonia. She's asking, can you please explain how to angulate the probe to obtain biventricular view from the apical four-chamber view?
Yeah, so when you get the apical four-chamber, you know the index mark is at 4 o'clock, you're right at the apex. So you go slightly above the apex, number one. Number two, slightly rotate toward the two-chamber, but not quite two-chamber. So you're going to rotate from the 4 o'clock, say, to the 3 o'clock position. And then you angulate the beam down till you eliminate the atria completely. And when you eliminate the atria completely, you'll get the biventricular view. The base will be the coronary sinus, and on that will be resting the left ventricle and the right ventricle. So that is the biventricular view. Very useful view, as I said, to look at the diaphragmatic wall of the right ventricle and to look at the basal infraseptal area of the ventricular septum to diagnose the post-myocardial infarction VSD after inferior wall MI.
Sure. So next, Shubhra is requesting for some tips in case of dextrocardia.
Yeah, very, very important question, that dextrocardia. And looks are very difficult, but it's not very complicated. So all that you have to do is to turn the patient right. Now, when you are imaging from the left parasternal region, don't see anything. If there's a dextrocardia, you'll not see anything. You are only going to see some shadows of the lung. And you try to give up. You don't see anything. You say very bad window. But before that, make sure that it's not a dextrocardia. So you turn the patient to the right and you put the probe in the right parasternal position. You put it in the right apical position, and you'll get the image. Now you'll get the image, so you can see the image, and accordingly the imaging points will be slightly different here. That what you get in the 10 o'clock position as the long axis view, you'll get in the 7 o'clock position, and the short axis view, what you get in the 1 o'clock position, you get in the 10 o'clock position, and similarly your apical views you also get. This position of the index mark will be slightly different, and you can handle that very easily actually. But don't get deterred when you're not able to see anything on the left parasternal. Move to the right parasternal. Once you see a good echo, you know that you're dealing with dextrocardia. Once you're dealing with dextrocardia, then you put it in the parasternal position, angulate the probe, rotate the probe, and get the parasternal position, short axis, long axis, and you look at then you put it in the apical position. Requires a slightly more skill, but it's not difficult. But the fact is that you should always look for it. The other way to look for dextrocardia, very importantly, is that whenever you're doing any examination, especially in a pediatric patient, you're going to always put the probe in the subcostal position to begin with. When you're putting in the subcostal position, then you're looking at the situs. Normally the IVC is to the right of the aorta. So when you go to the short axis position, you see the IVC to the left of the aorta, then you know that you are going to have a situs inversus. And then you can see whether the dextrocardia is going hand in hand with the situs inversus or not.
All right, sir. So there is a lot of compliment coming your way. People are thanking you for the excellent presentation. The following question is from Dr. Sunil. He wants to understand how to do RV inflow outflow.
Yeah. So when you're doing the parasternal long axis view, do you want me to show the image also, or you want me to just speak?
You could do that, sir. I mean,
I
people
can show the image.
That. Yeah.
So I'll just go to that image. Yeah. So I'll show you the image again, because you might have missed that, because of course it's a little rapid presentation.
So if you're getting back into your presentation, so there's also a question which you might want to address there. Pooja Sinha has requested you to repeat the site of transducer placement in the right lower parasternal view and imaging from the back. So if you can take these two questions together.
Yeah. So now here I've got the image of the RV inflow view. This is the diagrammatic view of the RV inflow view. So you can see that the index mark is going to be at the 10 o'clock position. The position of the probe is going to remain same, what you got for the long axis view. And the index mark is going to be at 10 o'clock. The only thing you're going to tilt the probe. Tilt the probe medially and inferiorly. And as you can see the wedge here. Can you see the wedge? And as you can see the wedge, sorry. Wedge, and you can see the wedge. You can see the right atrium and the right ventricle and the tricuspid valve. And you can see the image over here. Now you can see the moving clip of the RV inflow view. So this is the moving clip of the RV inflow view. This is the RA, this is the RV, the tricuspid valve. So this is the RV inflow view. And if I move out, now this is the RV outflow view. The RV outflow view, you're going to angulate upwards and outwards. That is superiorly and laterally from the same position. This position is in the fourth intercostal space. Index mark is at the 10 o'clock, and you're going to angulate the beam superiorly and laterally. You look at the RV outflow tract, and you can rotate it slightly from the 10 o'clock to the 11 o'clock position to look at better. Now this is at the 10 o'clock position, and you can see the RV outflow, the pulmonary, and you can see here that you're slightly tilted. You have slightly rotated towards the 11 o'clock position. This is the pulmonic valve, the mitral valve. So the mitral pulmonic vein, the outflow view from the parasternal position in the long axis. So this is one view. Now the other question that was asked was regarding, this was the second question you had told me.
Yeah, so just give me 1 second. There's so many questions.
No, this was.
Could you repeat the site of transducer placement in the right lower parasternal view and imaging from the back?
Yeah. So I'll show you here this right lower here. So this is the right lower transducer. This is the right lower parasternal. You can see that this is not a horizontal view, somewhat tilted with the LV somewhat on top, the LA is somewhat below, and aorta also pointing at about the 4 o'clock position. And this is at the parasternal position. The transducer is slightly lower than the fourth intercostal space. So it's between the fourth and the fifth, or sometime in the fifth intercostal space, but importantly in the parasternal position, not in the apical position. Because the apical long axis view will somewhat superficially look like this. But this is in the parasternal position. So you're getting a view of the apical segments of the left ventricle from the parasternal position. That is very important. Getting the apical segments of the left ventricle from the parasternal position, which is at a lower depth, so better quality imaging. So that is one, and you're getting the more of the apical segments, less of the aorta, but more of this apical, and you can see it moving. So this is the light pulse, and if you angulate slightly inferiorly from here, you can get what is called the apical tilt, and you can see the apex from here, from the parasternal position. Closer to the apex, I would not say is as good an apex as you get from the LV apex that you normally see from the apical position, but when you tilt it, you get closer to the LV apex, and this is the apical tilt, which you can look at the hypokinesis that is there, which are not seen in the classical lower parasternal. So, any other thing?
So yeah, sir, Dr. Shashidhara has also requested you to show standard views for pleural effusions.
So
I think there are a lot of questions around views, so maybe I'll keep, telling you one by one.
So I'll go to the last slide, which was actually showing you, or almost the last slide, which was showing you this pleural effusion. Now, if you want to look for the right, when you're doing the subcostal view, then as you are angulating to the right from the subcostal view, you can look at the right pleural effusion. When you're doing the apical view of the LV, when you're doing the apical view of the LV, you can move the transducer slightly more laterally and look for the pleural effusion. But the best way to look for the pleural effusions, either right or left, is to make the patient sit up and then image from the back. So if you place the transducer from the back, you are going to get this pleural effusion if it is there. Like this is the pleuropericardial effusion. You can see the parietal pleura and the parietal pericardium. This is the pericardial effusion. This is the pleural effusion. And you can see the view from the back here. This is the left pleural effusion. If you place it on the right side, if there's a right pleural effusion, you can get it. To exclude that there's a pleural effusion or not, scan from the suprascapular region to the infrascapular region from the back on both the sides to exclude if there's any pleural effusion. But you can get a preliminary assessment from the subcostal view for the right side and from the apical LV view, and you're going a little bit beyond, on the left side, you can get a preliminary assessment of the pleural effusion. Also from the parasternal long axis view, which is a large pleural effusion, you can get an echo-free space behind the left ventricle, making sure that your depth is not too small, that you're very superficial and you're getting an echo-free space there, but making sure that echo-free space is actually a pleural effusion. From the parasternal effusion, you can get an inkling that this is a left pleural effusion. But the best view is from the back.
Okay, so the next question is, yeah, how to visualize left superior vena cava and right superior vena cava?
Now, very important question about the left superior. Now, the right superior vena cava, I've just told you. Right superior vena cava, there are two views. The one view is the right supraclavicular view, where you get the origin, where the right and the left innominate vein join together to form the SVC. And then you can actually get the formation of the SVC, and toward the mid segment of the SVC, a vertical, as I said, from the right supraclavicular. I can show this particular view again. Yeah, this is the SVC view. So this is easily got. All you have to do is a little practice. So put the you can put the probe index mark at the 1 o'clock position in the right supraclavicular position next to the suprasternal notch. So on the right side of the neck. So this is what you're going to get the SVC view. Second is from the subcostal position. I said, as you get the subcostal four-chamber view and toward the subcostal short axis, as you rotate toward the short axis position from the subcostal, you angulate, become slightly anterior there. You can get the SVC coming, joining there. So the terminal part of the SVC, you can get from that position. So these are the two views. And if you're getting a good right parasternal view, that is another view. But in many patients in the middle age to older adults, you don't get a good right parasternal. But in the younger patients, you can get a good right parasternal window. And there also you can image this SVC from the right parasternal position. Now, as far as the left SVC is concerned, left SVC means that this is a left innominate vein which is draining into the coronary sinus. rather than joining the right innominate vein to form the right SVC, you are going to have the left SVC, where the left SVC has a connection to the coronary sinus, which is an embryological phenomenon, which normally gets closed, but in this case, in some patients does not get closed, sometimes associated with congenital heart disease like atrial septal defects or tetralogy of Fallot, but sometimes can be seen isolated. So how you look for left SVC? One of the very important is when left SVC is going to drain into the coronary sinus is going to be large. And where are you going to see the coronary sinus? Normally the coronary sinus is hardly visible. It's hardly 1 millimeter to 2 millimeters. If you take the parasternal long axis view, anterior to the descending aorta, that is a large round echo-free space of descending thoracic aorta, anterior to that, and just where the posterior leaflet of the mitral valve is joining the junction of the posterior wall of the LA and the posterior wall of the LV, at that point you get a very small echo-free space, which is the coronary sinus. But if this coronary sinus becomes more than 5 to 8 millimeters, becomes 1 centimeter or so, then gets very large and becomes very obvious. And the usual cause, most common cause of a prominent coronary sinus is left SVC. Now, one should know that this is going to be left SVC. You can do a contrast echocardiography. You can put a contrast, which is a normal saline contrast injected through the left upper limb. And as you will agitate this normal saline, you'll get contrast bubbles which will be imaged. And the first image you'll get is of the large coronary sinus. So if you get a coronary sinus opacified even before the right ventricle is opacified on the parasternal long axis view, then you know that you're dealing with the left SVC connection to the left atrium. But the first impression you're getting is a large coronary sinus. Now the other way to do it without using the contrast, what you're going to use is that you are going to put the probe in the suprasternal notch in the left supraclavicular position. So rather than in the right, which you put for the right, you put in the left, and you see an echo-free space anterior to the descending aorta, a long echo in the long axis, going parallel to the descending aorta but anterior to it, and trying to join the coronary sinus. So as you see that, and you put the color on, you'll see a blue flow anterior to the descending aorta. So that is the left coronary sinus. And you'll not see the this SVC, this left innominate vein, joining the right innominate vein. So you'll not see the left innominate vein on top of the arch of the aorta. You'll in fact see from the left supraclavicular view, the left innominate vein going vertically down, parallel to the descending aorta for the left SVC. So go on to the next question, please. Yes, sir. So for mitral wall planimetry, planning for BMV or MVR, can we go for 2D with transesophageal or 3D only is enough? Should I repeat, sir? That will depend upon the quality of the picture that you got. If you have a good quality picture from the parasternal short axis view, you have to make sure that you are at the tip of the mitral valve so that you take an accurate surface area. And you have to look at the subvalvular apparatus. You have to look at the mitral valve with a thickened, calcified, and you can grade it accordingly. The thickness and the calcifications and all can be graded. You can look at the commissural calcification. Whether there one commissural calcified, then that's an absolute contraindication. Then you don't need to go for transesophageal echo. And if you're thinking that the subvalvular apparatus is extremely short and markedly thickened, then that again is almost a near contraindication for going in. Similarly, if you're getting a mitral regurgitation, significant MR, again you should try to image the LA appendage. Now the LA appendage can be imaged either from the short axis view or you can get from the apical two-chamber view. So if you're getting a good quality image of the left atrium, you are sure that the left atrium is okay, is free. If you have any doubt, especially if the patient is elderly, having atrial fibrillation, and you're not getting as good a view of the LA appendage, then you should go in for transesophageal. Many people who are interventional cardiologists who are going to do BMV, they actually insist on a transesophageal echo before doing a BMV. But actually, you can get a good, it depends on the quality of the transthoracic echo. Any other question?
Yes, sir. So can you talk about the anatomic way? Hello? Can you hear me, sir?
Hello?
Yes, sir. So can I take the next question?
Yeah, please.
Okay, I'll just go back to the chat. So can you comment on the anatomical variants you might see in LV cavity that may pose diagnostic dilemmas such as tendons or ligaments?
Yeah, sometimes, you know, you are in a dilemma whether you're getting a lot of echogenic structures, which could be normal variants that are seen inside the left ventricle. So you can get false tendons, for example, which are horizontal linear echoes, which are going from the interventricular septum to the lateral wall. Those are called false tendons. You can get trabeculations. Normally, and inside the left ventricle, especially at the apex, you should not get 1 to 2 trabeculations. Once you start getting more than 2 trabeculations, sometimes people say that, is it a case of non-compaction? But you should not diagnose only on the number of trabeculations. The other criteria to diagnose non-compaction and not just the number of trabeculations, otherwise making a false diagnosis. So that trabeculations and false tendons, and sometimes, and many times you get artifacts at the apex. I said you get a near field clutter to show, and sometimes, you know, there is an apical wall motion abnormality. There's an apical dyskinesis, and you're looking for a clot and you get a clutter there and you think that that's a clot, and you make a wrong diagnosis, and the patient is going for bypass. The surgeon will open up the apex and try to take out the clot. And when he sees there's no clot, he's going to get very upset with you that you have told him to open up the apex and to take out the clot when there's no clot. So make sure that you are not dealing with an artifact. And one of the things I told you was to go to the apical short axis from the apical position. The other thing what you can do is actually to go for harmonic imaging. Tissue harmonics should always be there. Anytime when you're buying a 2D echo machine, it should always have tissue harmonics that will help to remove the apical clutter. The other thing is that before you do contrast echo, you can do the color flow mapping of the left ventricle by lowering the scale. So you can get a look at the apical flows. If you're looking at the apical flows, then you can see that whether their apical flows are overlapping with that artifact, then you know that that's an artifact. But if they're outlining that particular structure, not overlapping it, but outlining it, then that's a true LV apical clot. The other, of course, you can always resort to contrast echo. The contrast echo is performed contrast echo by injecting the contrast intravenously, and that from the right atrium, right ventricle will go through the pulmonary circulation on the left side, and you will image the left ventricle. The left ventricle endocardium outline is there. And if there is no clot, that's an artifact, then you know that you're dealing with an artifact and there is no clot at all. So the contrast echo becomes very useful sometimes to delineate that. So any other structures that you want to look for, or is that enough?
So there are a lot of questions, but you know, for the paucity of time, I'll take 2 more questions which are repeated, you know, by a lot of participants about Crabbe's view and specifically Crabbe's view with respect to pulmonic view.
No, what is actually the Crabbe view is actually looking at the drainage of the pulmonary veins, where they are draining and forming a common chamber. And where is that common chamber draining? You look at in the anomalous pulmonary venous circulation. So if you are suspecting a TAPVC, we're not seeing the pulmonary veins open into the left atrium. You're looking at the common chamber. So you try to visualize that particular common chamber from the parasternal short axis and going toward the suprasternal lesion, but a high parasternal short axis. You see the joining of the 4 pulmonary veins looking like a crab, And when they join together to form a common chamber, then you get a vertical vein coming over it, which sometimes joins the left innominate vein, but could join the coronary sinus also. So that is what is called the crab view, four-chamber view. In a patient when you are suspected to have TAPVC. Any other question?
There's a question from Dr. Inamdar. He's requested you to explain retroaortic innominate vein.
Well, generally the innominate vein, it goes superiorly, it can sometimes go inferiorly, and in the pediatric population can be easily diagnosed. As you look from the suprasternal position or the right sternal position, you can look at the retroinnominate vein, which is going, normally the innominate vein goes above the ascending aorta, here is going behind the ascending aorta, and sometimes it can get, encapsulated by the aorta, it can be caught between the aorta. But, generally it's a very rare condition that occurs.
On that, thank you so much, sir. You're a wonderful teacher, and somebody said that you are born to teach. You're an excellent teacher, so I quote the same participant as well. Thank you so much.
Thank you very much.